VBAC, which is for our listeners, vaginal birth after C-section or cesarean, which is a medically safe in many cases. Globally, places in like the United Kingdom or the Netherlands actively encourage VBACs if the clinical condition is right. But in India, it's rare nowadays, like 7 to 10%. And honestly, a lot of that comes down to system inertia and misinformation. So doctors here often are defaulting to telling women that once a C-section, always a C-section, as you mentioned, Divya.
Once a cesarean, always a cesarean. You've also heard this, right? Yet, every woman who had an unplanned surgery the first time around hopes secretly that she has a chance again. Many feel very attached, helpless, miserable, and that feeling that their body failed them the very first time around becomes real again. They hear this from women around, once a cesarean, always a cesarean, which feels unreal, yet they seem to have no choice. Is it? Do you not have a choice? We will break this down for you today, evidence style. Welcome to the Birth Agni podcast, the fire that births us and transforms us. This is a space where women reclaim birth on their own terms, where deep ancient knowing meets primal courage. We talk birth, womanhood, breastfeeding, parenting, and the quiet power of choosing differently. Choosing of our own. Come as you are, leave more rooted. I'm Divya Kapoor, a childbirth educator, lactation counselor, trainee traditional midwife, and doula, disintegrating the politics of birth, one story at a time. Before we get knee-deep into the world of VBACs, vaginal birth after cesarean, I wanted to share that a lot of effort goes into creating every episode. From research to presentation to editorial team, every episode is made with utmost care to bring the most authentic information out there. And we are proud to be the pioneers in this niche in India. Our aim is for every parent to have a choice, which is of their own, not handed out to them as a mandate. If you like our work, here's a simple request. Give us a rating or review on the app you're listening to us from. Take a moment right now. Apple Podcasts or Spotify, even better. You are in this mission with us together. And honestly, as a birth keeper walking with women end to end in their pregnancies, I have seen how evidence many times does not have the final say. An individual analysis from an expert often helps find the right direction, and that has been the basis of any area of care, say homeopathy, allopathy, or naturopathy. That is what moved these care modalities forward and evolve. Evidence does not have a final say, but it is crucial, especially right now when there's a lot of noise which is becoming bigger and bigger than reality. VBACs, vaginal birth after cesarean. And we will use a term today, TOLAC, which is trial of labor after cesarean. First thing first, let's clear the dust right away. The first research paper. Is vaginal birth after cesarean, VBAC, or elective repeat cesarean safer in women with a prior vaginal delivery? The objective of this study was undertaken to determine whether vaginal birth after cesarean or elective repeat cesarean is safer overall for a woman with a prior vaginal delivery. The conclusion was, among VBAC candidates who have had a prior vaginal delivery, those who attempt a VBAC trial have decreased risk for overall major maternal morbidities, as well as maternal fever and transfusion requirement compared with women who elect repeat cesarean delivery. Physicians should make this more favorable, benefit-risk ratio explicit, meaning tell more and more parents that, where is the benefit? is the benefit more in VBAC, which is what it is trying to convey. So physicians should make this more favorable benefit-risk ratio explicit when counseling this patient subpopulation on a trial of labor. So to answer the question of the possibility, can you have a vaginal birth after surgery? Do you have a choice? A big yes. Yes, you do have a choice. Once a cesarean, always a cesarean is a brutal lie, not backed by evidence, let alone physiology or how your body functions. You may ask, but Divya, I checked with my doctor and she said, once a cesarean, always a cesarean. What should I do? Well, change your doctor the moment you hear this. It is unfortunate many doctors are scared of attempting VBACs, and hence it is often a provider's lack of skill than your ability to have a vaginal birth after cesarean. Our work with this podcast is to provide you with authentic, physiology-backed advice and expose protocols that harm women and children but serve the corporate motives of the hospitals. You may again ask, but then, Divya, why are doctors scared? They talk of uterine rupture with attempting VBACs like they are sure that is going to happen. Great question on uterine rupture. Let's dig into uterine rupture and the chances of it by research. Risk of uterine rupture in vaginal birth after cesarean. Systematic review. The objective of this study is to assess the risk of uterine rupture in attempted vaginal birth after cesarean and to identify risk factors. The result? A total of 39 documents were included for their relevance and interest. Few clinical trials were found. The uterine rupture incidence on the results of the studies analyzed range from 0.15 to 0.98% in spontaneous labor, 0.3 to 1.5% in stimulation and induced labor with oxytocin, and 0.68 to 2.3% in prostaglandin inductions. Conclusion: the success of vaginal birth after cesarean is important and improves when conditions are optimal. However, it is not without risks, the main one being uterine rupture. Induction of labor with oxytocin and or prostaglandins appears as the main risk factor, while the spontaneous onset of labor and a prior vaginal birth are protective factors. This research paper tells us that the chances of a uterine rupture are as low as 0.15% if you go for spontaneous natural labor, and the risk increases only if you are slated for induction in any way. If you look at the trends even with VBAC in the West, doctors are still inclined to induce you with a smaller dose knowing that it can cause uterine rupture if you go beyond 39-40 weeks, which is absurd to me. You may say, Divya, but the chances only slightly increase. Well, experientially, according to my experience, with my observation as a doula and as a trainee midwife, when I come across women from across the world with various use cases trying for a VBAC, I have seen over 50% rise in cases of uterine rupture with an induction. Even if I give an estimate, 50% is a safe number to say that induced women will rupture their uterus than spontaneous labor. Well, why risk women then? Is trying for a VBAC in itself not risky? Why risk any chance of a uterine rupture? Yes, because birth in itself does not come without risk. Even for a first-time mother, there is always a minute chance of a uterine rupture. Let us not go too far to view if a first-time mother is immune to rupture. This study that I'm about to share is from Nepal, the way birth is portrayed. And the problem is, the way birth is portrayed, we do not talk about a rupture at all for a first-time mother, making it sound like she's immune to it. But we speak greatly of it after a uterine surgery, as if it is very, very common. Both are wrong. The issue is women with a previous cesarean are not allowed a TOLAC, trial of labor, and hence data around it for Indian women is next to nil. Because we are not letting women go into labor at all, but the world is, and hence the rates of uterine rupture after a cesarean in unmedicated birth is reported to be as low as 0.15%. Here's the study on rupture in uterus in primi gravida, meaning first-time mom, morbidity and mortality. What's the objective? The paper is aimed to present rupture of the uterus in primi gravida, unscarred cases, which are supposed to be extremely rare. I'm reading from the discussion section here. Another patient had breech and cord presentation. This patient was enhanced the labor with syntocinon drip, which is an induction, a drug to induce. 3 of them had prolonged labor, out of which 1 had vaginal delivery with episiotomy, and the rupture of the uterus was detected after 5 hours. 1 with a history of fall, meaning an accident, at 38 weeks of pregnancy, giving rise to abruptio placenta and uterine rupture. A case who was aged 37, had a history of treated for subfertility including DNC done at 18 months back, had the fetus and the placenta in the abdominal cavity on admission, that means the uterus had ruptured. What were the findings of laparotomy? The lesions found were ruptured bladder and complete lower segment up to the cervix in the woman who was induced with syntocinon. There was complete lower segment rupture, complete upper segment, complete upper and lower segment, where 1 had a tear at a posterior wall of the uterus, so on and so forth. The discussion is, rupture of the pregnant uterus is a catastrophic obstetric complication which in primi gravida is supposed to be extremely rare. 15 cases, 6% of primi gravida, nulliparous, ruptured uterus have been presented here, giving an incidence of 1 in 18,150 live birth, meaning 0.5% of the births, 1.5% in 10,000 births, which definitely gives us a message that nulliparous or primi gravida uterus is not immune to rupture. Due to illiteracy, poverty, and socio-cultural beliefs, early marriage is common in Nepal. The geographical diversities make the issues even more difficult for free communication. Maternal mortality and morbidity have remained very high in developing countries, and one of its commonest cause is ruptured uterus, which in a primi gravida is rather unusual. There's another study where the background is a spontaneous rupture of the unscarred uterus in primi gravida patient is extremely rare and is associated with high perinatal and maternal morbidity and mortality. The conclusion of the other study is a rupture of the pregnant uterus should always be considered in a pregnant woman representing with abdominal pain, even in a primi gravida patient. So no, you are not immune to uterine rupture, and the difference in the rupture rates for the first-time mom is similar, if not more, than with the previous cesarean. The reasons for uterine rupture as indicated in the Nepal study was prolonged labor, medical interventions such as the use of induction in a woman with prolonged labor, and a different shape of the uterus. Similar reasons are there for women with rupture with previous surgeries, as well as the intervention in VBACs with induction being absolutely counterproductive for a VBAC mom. If you are listening to us for the very first time and do not know if induction is counterproductive for a first-time mom, and in general, listen to episodes on induction 83, 88, 101 and 106. Here you will learn all about inductions and the experiences of women who were induced in one of the births and the other they were not induced. So you'd see that they had a different experience both time around. Now you may say, Divya, I was better off knowing I was immune to rupture being a first time mom. How do I approach my birth now? Well, love, there are two ways to look at it: a glass half full or a glass half empty. Risk of a rupture for a first time mom is really low. And what you also learn here is that it is really low for a woman with a previous surgery, if the birth is not managed or the woman is not induced. Induction is one big culprit for uterine rupture, both in the first time moms and one attempting a VBAC. Is a repeat cesarean safer for you than a vaginal birth? Let's see. Multiple repeat cesarean sections, is it safe? Patients without any obstetric risks with 2 or more previous cesarean sections had significantly more dense adhesions. Adhesions is when you're at the site of the scar, when your tissue, the scar tissue, becomes really tight and attaches to the organs beneath the layer, and that causes multiple organ issues. And uterine wound separations in the current cesarean section compared to patients with one previous cesarean section. But maternal and fetal mortality and morbidity in women have not known to increase with previous cesarean sections. I think if you count the health of the mother and the baby with repeat cesareans, it is definitely compromised if you have more than one cesarean sections or even just one. It is a major abdominal surgery and it comes with its own side effects. And then there's another study, the impact of cesarean section on neonatal outcomes at a university-based tertiary hospital in Jordan. Among the babies electively delivered at term, early term, 37 to 38.6 weeks, 16% were admitted to the NICU for a median length of stay 4 days. The most common diagnosis for admitted term neonates were transient tachypnea of newborns and respiratory distress syndrome, meaning surgeries anyway cause respiratory distress, even more if it's preterm, 37 to 38.6 weeks, something which is rarely discussed. Another very important point. So now, outside of research papers, chalo, let me tell you about the common issues with repeat cesarean sections in general. One issue is excessive bleeding post-birth, respiratory distress in babies, more NICU admissions, baby deficient in the gut bacteria, reduced immunity of the baby, maternal adhesions at the site of the scar, and pelvic floor issues with repeat cesarean sections. These are some of the common issues that women have after cesarean sections. What do I do now, Divya? TOLAC. A trial of labor is your best friend. And without induction. Why? Here's another study. Uterine rupture and subsequent pregnancy outcome. How safe is it? A 25-year study. The conclusion of this study says that in the previous cesarean section, the indiscriminate use of oxytocin and malpresentation are the risk factors for uterine rupture. Not just oxytocin, the baby malpresentation is also a risk factor for uterine rupture. Childbirth after uterine rupture is not to be recommended routinely. Most women with a previous uterine rupture with meticulous tertiary level antenatal care had a favorable outcome in subsequent pregnancies. So do not get induced if you're trying for a VBAC. Another study supporting trial of labor says, so the study name is Trial of Labor After Cesarean for Vaginal Birth After Previous Cesarean Section versus Repeat Cesarean Section, a review. The background is cesarean deliveries have been on the rise in recent decades, and as a result, the question of how to manage subsequent deliveries becomes ever more important. Historically, repeat cesareans were thought to be the only option. However, multiple studies have shown that successful vaginal birth after cesarean has the lowest rate of maternal morbidity and mortality compared to elective repeat cesarean section. The controversy lies in the risk associated with unsuccessful VBAC, which is associated with an increased risk of uterine rupture and maternal mortality. What's the objective of this study? To compare the risks and benefits of VBAC and elective repeat cesarean delivery, examine the characteristics of VBAC candidates to predict trial of labor after cesarean TOLAC, success, and comment on the current recommendations for delivery management after prior cesarean section. What's the conclusion? Trial of labor should be recommended to all women who have had only one previous cesarean section, except for previous classical or T-uterine incision, which is like a big uterine cut, which is no longer used, so you're safe. More than one cesarean has been performed. That means a lot of women are never told that if they have had more than 2 surgeries, their chances of having another vaginal birth is nil. If you've had 2 cesareans, no doctor in India will admit you for a TOLAC at all. You will have to have another surgery if you want another baby. Previous hysterectomy or full thickness myomectomy, these are uterine cuts. Previous uterine rupture, any contraindications to labor in this pregnancy, say placenta previa, transverse lie, which is normal for a first-time mom also. If there's a placenta previa, you cannot go for a normal birth. If there's a transverse lie, meaning the baby's position is not okay, you cannot go for a normal birth, either for a VBAC or a normal birth as a first-time mom. Or if previous surgery was performed for failure to progress in the active phase of labor. These guidelines are suggested by evidence gathered from the literature and recommendations by experts in the field. However, decisions should be made by a case-to-case basis. It also says that twins, suspected fetal macrosomia, meaning a baby that may be suspected to be big in size, and diabetes are not contraindications for VBAC. So if you are a mom who is second time pregnant, had the first primary C-section, you're pregnant with twins this time, you have a supposedly big baby, you may have gestational diabetes, these are not counterindications for VBAC. You can still go for trial of labor. Go for it and vouch for as unmedicated trial of labor as possible. And with this, we come to the end of the episode. What did you learn? You learned that women who go for a trial of labor post previous surgery have more favorable outcomes in terms of their health. They have more successful VBACs, more successful vaginal births after cesareans, that is, better maternal outcomes and baby outcomes. It's a possibility, and many women are candidates for TOLAC, trial of labor after previous surgery. If you have any questions still, feel free to reach out to me via a discovery call. I prepare my moms one-to-one for VBACs, taking them through the various aspects of VBAC, as well as provide nutritional and physical guidance to maximize their chances of having a vaginal birth this time around. A strong uterus, a strong sac is possible with nutrition and a lot of work with the mind, and it alters our direction with respect to birth. So this is how I prepare my moms. If you have any questions, please feel free to reach out to me. And don't forget, the first 20 applicants receive an extended free birth guide. There is a limited time to sign up. Visit www.birthagni.com and sign up for the free childbirth guide. Guide launches 1st September 25. Avail the offer now. And as usual, thank you so much for listening. Continue sharing this episode and spread awareness not just for you and your loved ones, but for the community at large. You can be a part of this huge change already unfolding in women who have started respecting their bodies much more, and they're getting their bodies and safety back by their own informed decisions. Let's do the best we can. And remember, you got the power. Love, Divya. There is a field beyond fear, where the body is empowered to take on labor and birth. To land there, it is crucial to take birth education. To enroll into our unique labor and birth preparation course, reach out to us at www.birthagni.com or scroll through all available prenatal and postnatal preparation classes. Thank you for listening, all in the spirit of birth, womanhood, and freedom. Remember, you got the power. This podcast is about physiological birth and does not offer or claim to provide medical knowledge or diagnosis.
Starting a podcast with poor recording tools in the market? It was painful until I found Zencaster. Its high quality audio and video recording, along with the option of a backup, makes it super sturdy and a savior at times. With an easy to use dashboard and super convenient tools for advertising campaigns such as reels and videos, Zencaster is my comfort choice. Go to zencaster.com/pricing and use my code BIRTHAGNI, BIRTHAGNI, and you will get 30% off of your first month of any Zencaster paid plan. I want you to have the same easy experiences I do for all my podcasting and content needs. You may also explore their free hobbyist plan to begin with.